Hello, and welcome to Chapter 4. This week, we're going to talk about prenatal development and birth. The content this week is fairly straightforward, and it should be easy for most people to remember because, after all, you grew up hearing probably most of your life about relatives or friends who were pregnant and the stages of development, and you've seen it throughout your life on TV and in other media formats. My guess is you probably even covered this content in high school. So let's do a quick review of what you need to know. There are three main periods of prenatal development that you need to know: the germinal period, the embryonic period, and the fetal period. The germinal period is the first 2 weeks of development. There's only about 16 cells, but it is the time when there is differentiation. And this is a time when part of the cells divide and they form the placenta, and another part of the cells divide and they form what will become a baby. From this point forward, however, until birth, you will not hear me refer to it as the baby, but rather by the correct terminology, which I want to make sure that you learn and that you use. The first task of this lump of 16-ish cells is to implant in the uterine wall. Now, you might think that this is easy, but it is not. In fact, it's estimated that about 60% of all the zygotes do not grow or implant. These women, as a rule, they will never know that they even conceived. So 60% of the people that conceive do not even realize that they did. From the third week on, we refer to it as the embryonic period, and this is an exciting period of development. Things are happening every single day that's helping to develop this new life. At about 14 days in, there's something that's called a primitive streak. And this streak is what eventually becomes the spinal column. Soon after that, you have the head, you have eyes and ears and a nose and a mouth, and you start to see these minuscule little blood vessels that will become the heart. By the 5th week, you see the buds of arms and legs. And by week 8, post-conception, the embryo has organs and body parts, all the body parts of a human being, essentially. It is developing from head to toe. And at that point, you see what many people recognize on very early ultrasounds as basically what they will eventually see as something that has human form. Now, it's important to remember that at this point, we're about 8 weeks in. You don't know if this embryo is male or female because the early embryo has both male and female potential. Finally, from the 9th week until birth, we refer to it as a fetus. This is when you start seeing rapid growth. In the embryonic phase, you had about 1 inch and 1 ounce of human potential, and now in the fetal period, you are going to see that grow very fast, very fast. Um, by 3 months, the fetus weighs about 3 ounces and is about 3 inches long. By mid third month, or basically the 4 month old fetus, you are going to have a heartbeat. It is stronger and it is faster. There's digestion and elimination. And after that, you start getting the full development of the brain. Before this, if the fetus is delivered or born, it doesn't have the functions to be able to live on its own. At the point that it does have the functions and the abilities to live on its own, that is called the age of viability. Currently, the age of viability is considered to be about 22 weeks. Before that, death is certain. Even in the fetal period, about 5% of all fetuses are aborted spontaneously before 22 weeks. This we refer to as stillborn, which means they are born dead. In the last 3 months is when the brain and the body is beginning to fully develop. The growth is very rapid. It's when women start looking what we refer to as very pregnant. The valves of the heart go through their final stages of maturing, as do the arteries and the veins in the body. And the testicles of the male fetus descend. In the final phases of the fetal period, the fetus grows about 4.5 pounds. By the time of birth, the average birth weight is about 7.5 pounds. One of the things that you will eventually learn in your pediatric nursing course is about the fontanelles on babies when they're born. And these are the two portions of the skull that are not firmly connected. So they haven't fused yet. And it gives this soft feeling to the baby's head when it's born. This is really important because when the baby comes through the birth canal, you want it to be able to be squeezed just a little bit. However, in preterm births, one of the problems is that the fontanelles can be too far apart. In other words, there's too much space in between them, too much of this very soft space. And it can make it easier for the baby to then have brain bleeds and to suffer trauma. There are other ways and other terminology that we use when we talk about pregnancy. One of them, and you have probably heard this before, is people talk about trimesters. The first trimester is the first 3 weeks. The second trimester is the first 3 months, second 3 months, and then third 3 months. We also talk about pregnancy and when it begins. So pregnancy begins at conception, and that is the beginning of the gestational age. But remember that when we calculate due dates, we do that based on the woman's last menstrual period. And the last menstrual period is usually about 14 days before conception. A baby then is considered to be a full-term birth 2 weeks before the due date or 1 week after the due date. It's time to quiz yourself a little bit. What do you call a baby born 3 weeks early? Take a moment to think. If you said preterm, that is correct. At about 38 weeks, between 38 weeks and 41 weeks, the woman gives birth to a child. The process of labor for a first child is approximately 12 hours, although it can be much longer or much shorter. And with the second child, it is about 7 hours. Again, we refer to a full term birth as any birth that occurs between 2 weeks before the due date and a week after the due date. It may be of interest to you that what stimulates the labor process is the development of the infant's brain. And it signals this massive increase in the hormone oxytocin. And that is what begins the labor process. How women labor and give birth is very much dependent on their culture. Many physicians prefer the woman to be on her back because it is easier for them to visualize the process of birth. But in the current situation, you have many people who use midwives, who have doulas, who are women or providers who basically assist them through the labor, such as counting contractions and other tasks. And there are different ways that women can feel more or less comfortable. If you ask a woman to lay on her back who feels more comfortable sitting up, that is obviously going to make for a much less pleasant and enjoyable experience. It is then really important for people to understand in advance what the woman's preference is. The newborn's first 5 minutes are really amazing and important. They take their first breaths, they can cry, their lungs function, their blood is flowing on its own. The infant's color changes, and we measure this through what we refer to as an Apgar score. Apgar scores are what we look at in the delivery room. It is essentially looking at the appearance, the pulse, grimace, activity, and respirations. They apply points to that, and an Apgar score can be between 0 and 10. Below 5 is an emergency. At that point, they would ask for a neonatal pediatrician to come. 7, 8, 9 is what most babies are. And of course, 10 means it is almost a perfect response. Many years ago, nurse midwives played a big role in the delivery of babies. And then we went through a time about 50 years ago where that changed, and physicians decided they did not like nurse midwives doing that role, and it changed. And we seem to have now come full circle where people realize that midwives play a valuable role, and the delivery of infants, of babies by midwives is very safe, and it is very effective. Midwife births, for example, have lower rates of complications and interventions. Now, some people will say, then do physician births, and in part this is because of the breathing and the massage and the social services they provide. Now, it's also because high-risk pregnancies are usually given to the physician. So there's two sides to this coin. There are times when you need a surgical intervention, and those are called cesarean sections, which we refer to as C-sections. In these cases, the fetus is removed through an incision in the mother's abdomen instead of being delivered vaginally. C-sections amount to about 21% of all births worldwide. However, it's interesting because they're only medically indicated for about 10% of births. The question is, why do we do this? Well, surprisingly, there are some advantages to both the physician and the mother to C-sections, which many of us may not consider an advantage, but some may. For example, it's more expensive to have a C-section, which means that hospitals make more. But also, it's more predictable. Moms can actually schedule exactly when they're going to deliver. So it can be both an advantage to the mother and to the hospital. There are disadvantages that do appear later. Mothers that have C-sections are less likely to breastfeed. They are more likely to have babies that have higher rates of asthma and obesity. And then there are other issues that may arise, as with any surgical procedure. When a child is born, there are many inherent risks and things that can happen throughout the pregnancy and in the process of delivery. There are many risks that, as a nurse, you should be aware of. We all see dramatic examples in people that have cerebral palsy. It was once thought that this was always the result of either too many medications or a slower breech birth or something the physician did using forceps. And now, of course, we know that is actually not accurate. That it probably begins with genetic sensitivity and then things that happen during the course of the pregnancy, some of which are the fault of no one. They are infections that the mom can pick up while pregnant. And then, of course, they can be exacerbated by things like insufficient oxygen at the time of birth. Anytime there is a lack of oxygen or not enough oxygen, we refer to that as anoxia. It often occurs for the second of two births, or when there is a lower or slower fetal heart rate. And one of the things we do now is we monitor the fetal heart rate to make sure that it isn't dropping too low. And by this monitoring, we are able to make decisions about how to proceed in the process of delivery. In addition to this, we also have teratogens. And this basically is any substance that can cause harm or defects. It can be drugs, it can be viruses, it can be pollutants in the air, it can be malnutrition, it can even be stress. And these can then result in abnormalities and birth complications. One recent example is Zika. Zika had lived for years, but until we had an outbreak of it, that spread much further than where it normally was and impacted wealthy countries like the United States. We did not realize the harmful impact on the fetus. So, for centuries, people didn't know what was causing some of the problems, specifically with microcephaly, which is a small brain in a fetus. And then when we had the Zika outbreak in the United States and other countries, we realized the harm that it could cause to an infant. One of the things that it's important to remember is that the impact, whether it's a drug or a substance used or an infection, is related to critical time periods during the pregnancy. Some of these teratogens can cause damage only during critical periods. So it matters where a woman is in the pregnancy cycle and what they should avoid. If you look at the attached chart, you see the development in your top row of the fetus and what is developing at what time. So the central nervous system or the heart or the eyes or ears. And then you see things that can happen. So central nervous system and the critical periods. You probably need to make sure you remember these critical periods because there are many things that you will study over the next few years that will be specific to those periods. One of the things that can have an impact, for example, is something we refer to as a threshold effect, which means how much of something did someone get and how often did they get it. So, how much of an exposure is enough to cause a harmful impact? One of the unfortunate things that we think about in these terms is fetal alcohol syndrome. How much alcohol can you drink before you put the fetus at risk? Early in pregnancy, a woman with heavy drinking is more likely to cause great harm to the fetus because it is such a critical time for neural tube defects, and it's also a critical time for the entire development of the CNS system or the central nervous system. This is why we currently advise pregnant women not to drink alcohol at all. But as we know, many women do, and in certain countries it's still culturally acceptable to drink during pregnancy, although in moderation. In the countries that do that, most of their babies do seem fine. But again, the question is how much and how often. So in the United States, our recommendation is if you are pregnant, do not drink. Essentially, there are three critical times that can cause harm or teratogenic effects. And the three things you need to remember are: one, there are substances that can cause harm. Two, there are critical times when those substances can have a more significant impact on the development of the fetus. And third, there is always the innate vulnerability, in other words, genetic predisposition to whatever the impact of the substance may be. We need to remember all three when we are providing care for pregnant women. Other issues that may be faced by a new mother are infants that are born and described as low birth weights. And of course, there are consequences to low birth weight. The most common cause of low birth weight in most countries is actually malnutrition. According to the World Health Organization, low birth weight is less than 2,500 grams or 5.5 pounds. Very low birth weight is under 1,500 grams or 3 pounds and 5 ounces. And extremely low birth weight is under 1,000 grams or 2 pounds and 3 ounces. The three most common causes for low birth weight babies are malnutrition, drug abuse or substance use, and the third is multiple births. So if you have twins or triplets or quadruplets, then you are more likely to have low birth weight babies. Sadly, even if the birth weight is corrected in early childhood, some of the complications from low birth weight can continue throughout a child's life. I'm not sure how much of this is related to the actual low birth weight and how much is related to actual continuing social problems within our society. But what we need to remember is that a lot of these children continue to have problems, both emotionally and intellectually, in their development. We talked earlier about plasticity, so it's important to remember by age four, some of the extremely low birth weight babies have actual typical brain development, especially if there were no other medical complications. This is one of the cases where we then have to look back to the nature versus nurture argument and determine what we can best do for children that are born low birth weight and how we can give them the best chance in life and help to make up for any of the problems associated with their low birth weight. There are many things for you to remember about new families. New families aren't just new moms and new dads, but they're new siblings as well. They're new grandparents. And the whole family plays an important role in the development of a child. There are some times when a mom gives birth and the woman, because of changing hormones, will experience postpartum depression. She may feel inadequate and unable to care for her new child. The first time is usually that there is something that's not quite right. The mother may not be able to sleep, she may not be talking to other people, and she may not be eating normally. And these are signs we should always look for. But new fathers, remember, they're new fathers just like new moms, and while many people may not think so, they also have the impact of psychological changes and biological changes. It's really important that the fathers also bond with their new babies. They are crucial in supporting the families. And they also have many biological and psychological impacts when a child is born. In those early hours after the birth of a child, the families will bond, and they call it parent-infant bonding. It is a strong and loving connection that forms between the infants and the new baby. There are many practices people have, some of them cultural and some of them just things people think are important, like a parent having the infant directly against their skin. There's actually not any real research or evidence that shows that this has a benefit, but it's not really our place to interfere with it when that is what parents want to do. I would highly recommend that you read carefully the chapter, that you specifically look carefully at what occurs during the different stages of the pregnancy and the important developmental stages during pregnancy, and make sure you're aware of substances or environmental toxins or other diseases that can cause harm during those critical periods. As always, there are additional presentations within this week's coursework that you can take a look at that I think may be useful to you. There is little that will be more useful to you than reading the chapter carefully. If you have any questions, remember, office hours are on Monday morning and Monday evening. Feel free to drop in. Thank you.